Ovarian Cancer Canada is building research capacity as well as unlocking insights into rarer forms of the disease. I would now like to introduce you to Dr. Anna Tinker, who will speak to us today on the treatment of low-grade serous ovarian cancer and why one size doesn't fit all. Dr. Tinker is a medical oncologist at BC Cancer and a clinical associate professor in the Department of Medicine at the University of British Columbia. Her clinical expertise is in the treatment of women with gynecologic cancers. Her research interests are in the area of clinical development, immunotherapy, and translational research. Dr. Tinker will be interviewed this evening by two members of our patient partners and research team, Donna Pepin from Barrie, Ontario, and Erin Barrett from Vancouver, British Columbia. So thank you all for joining us, and I'm going to pass it over to you, Dr. Tinker.
Hi, good evening, everyone. It's a true honor for me to be here. Thank you very much for inviting me. I really look forward to our discussion. I think you've heard my introduction. I treat women with gynecologic cancers as my primary clinical focus. And I've been asked to speak to you folks today about low-grade serous ovarian cancer. And then, we'll engage in a discussion. I think if I'm correct, and if it's okay for me to take the lead, I meant to give you a little bit of a very quick overview of what low-grade serous ovarian cancer is, or what we understand so far. And it's very brief, just a few slides. And that will hopefully set the tone for, some of the discussion we're going to have coming up. So I'm just going to try to share my screen. And I apologize if I look off to the side. I have two screens, so it's just a little easier if I have things on two different screens. Okay, so what are you seeing now? I hope you're seeing a screen that says low-grade serous cancer of the ovary.
Yes, we can see
my
it. Opening
slide. Okay, perfect. Thank you. Okay, so let's just talk a little bit about low-grade serous cancers. So as you all know, and I know I'm speaking to a very well-educated crowd, we have multiple ovarian cancer subtypes, and understanding this has really shaped how we approach patient care. Low-grade serous cancers are one of the 5 most common subtypes, but they are amongst the least common of those 5, representing roughly 5% of ovarian cancer diagnoses. They sometimes have a precursor lesion. They can arise out of a more benign change called a serous borderline tumor, but not always. And as far as we know, this type of cancer is not associated with hereditary syndromes, which is good for families. But oddly enough, it does affect women who are slightly younger in their age, which is something we see more often with hereditary syndromes. Nonetheless, this is not usually inherited. And as we study cancers more and more, and we study all these various molecular and histological subtypes, we realize that low-grade serous cancers have their own special mutations. KRAS and BRAF are some of the common ones we talk about, but there are other mutations being identified. And knowing that is important because that means that we know of a pathway that might be active in these cancers. And this pathway can sometimes be targeted by specific treatments. In our case, we're talking about something called MEK inhibitors. So this is another representation of the sort of the frequency of low-grade serous cancer as being very low frequency. And important in this as well is that unlike the more common type of serous cancers called the high-grade serous type, these tumors don't usually have a P53 mutation. They're not associated with BRCA1 and 2 mutations. They have a very different look to them under the microscope. They don't look very aggressive. They sometimes have these little calcium deposits, which you see here as little dark dots, which tell the pathologist that this might be a low-grade type of slower growing cancer. So the patient characteristics, as I mentioned, are often women who are diagnosed at a younger age. It's really important because it can affect women during their productive years of life when they might be young mothers. They're still in the workforce. They might be looking after their own parents, and then they are affected with a cancer like this. Although it's low-grade serous cancer, it is actually very often diagnosed in an advanced stage. So it's quite common to see it having spread already inside the abdominal cavity, much like we see with the high-grade variant. And although most women with low-grade serous cancers tend to live longer than their high-grade counterparts, we do see women whose disease can progress quickly and can be very difficult to treat. And definitely it is a very serious and life-threatening disease for many women who are diagnosed with it. As we study these cancers more and more, we realize that nothing is as simple as just seeing one or two different types of genetic changes. My colleague, Dr. Mark Carey, who works closely with us in BC and is well known for his research in low-grade serous cancers, has started modeling and studying a low-grade serous disease and looking at the different type of molecular groups that might be identified. And sure enough, there's more there than just knowing that it's not a hereditary cancer or that it expresses KRAS or has a KRAS mutation, or that estrogen receptor is often present, which is a feature of this disease. It very often expresses estrogen receptor. So now that we know there might be a few different types of groupings of this disease, it influences how we might think about it going forward, and we might have to increase our sophistication as we research this disease further. So when we think of treatment, as for all gynecologic cancers, of course, good surgery is important. And we do want our patients to have the best surgery possible, hopefully with a gynecologic oncologist. Sometimes women will have multiple surgeries. Sometimes they will have a surgery, and if the cancer comes back, they might have a second surgery, and sometimes even a third if it's still felt that surgery can do a good job at removing the cancer. Chemotherapy is challenging with this disease, and this is a theme across cancer. Slower growing tumors do not respond as well to chemotherapy because chemotherapy mostly depends on DNA replication being disrupted. So if cells are not replicating very quickly, when we give chemo that goes into the system and then gets cleared out of the system, if the cells weren't replicating at that time, they may not be affected by the chemo. So the response to chemo is considered quite low for this disease. Some women will respond, there's no doubt. I don't want to say it's not useful, but it's certainly nowhere near the response we see with the fast-growing serous cancers. And as I already mentioned, most low-grade serous cancers express the estrogen receptor. This is something seen in various cancer types, and breast cancer would be the perfect example of one of the well-known types of cancers that express estrogen receptor. And anti-estrogen is a treatment option. Now, getting the cancer to shrink with anti-estrogen treatment is not that easy, but the cancer can be very stable on anti-estrogen treatment. And down here, I've just put in some pictures of how the pathologist would study the cells to see if it expresses estrogen. And here you see this brown staining is an immunohistochemical test that the pathologist has applied to a low-grade serous cancer. And they can see that compared to, say, a negative control, this stains positive for estrogen receptors. So this is a common thing that we test for in low-grade serous cancers, and anti-estrogen treatment is a common strategy that we would use to treat this disease. So the National Comprehensive Cancer Network, which is basically an organization out of the United States, has pretty much created this treatment paradigm, and I don't want to go through it in great detail, but it gives some guidance over what to do in different stages of the disease. And you can see here chemotherapy for women with advanced stage disease, so stage 2, 3, and 4. Chemotherapy is an option, but also hormone therapy is an option, one or the other. And if a patient is given chemotherapy, they might go on to hormone therapy after. So hormone therapy is an important component of what we do for this disease. If women have progressed after their initial therapy, as I mentioned, surgery might be an option, but there's a new strategy now looking at something called MEK inhibitors. So remember I mentioned that KRAS is an often abnormal signaling pathway in these cells. And downstream from KRAS, I don't know if we can see KRAS that well in here, and I'm sorry, this is a busy little picture, is something called the MEK protein, which is a signaling protein that eventually down this pathway tells the cell time to grow. So if we can interfere downstream of the KRAS, RAS, RAF, MEK pathway, then we might be able to block these growth signaling pathways and get the cancer to slow down. So that's been studied with a drug called trametinib. It is a MEK inhibitor, works right here by blocking this pathway. And it is a good drug in the sense that we see patients will respond to it. And many, many patients have stable disease when they take this drug. And we see that the survival of patients is improved when a trial was done comparing this MEK inhibitor against a physician choice of treatment. Unfortunately, the treatment has side effects, and probably between 25 and 35% of women might come off of it due to side effects. We've designed a trial, and this is a trial that's garnered some support from Ovarian Cancer Canada, and I'm really thrilled and thankful for this. And this is something we're really hoping we will succeed in launching. It's going to take us a little bit of work, I think, but we are certainly moving towards that. And this is a trial where we actually want to look at targeting both the estrogen receptor and this MEK pathway together. So that's not been done before. And there's actually some other scientific rationale for doing this. So people have looked at this in cancer models and they see that it might have an impact. And we want to give patients a MEK inhibitor, and we want to give them something called a serum, I'm forgetting what the S stands for, estrogen receptor, selective estrogen receptor degrader, which is a new, even more powerful anti-estrogen treatment compared to, say, letrozole or other treatments we have. And we want to see how a MEK inhibitor compares to one of these new anti-estrogen treatments and how they also compare to when they're combined together. So we've been very, very fortunate to have the support of Ovarian Cancer Canada in trying to move this study forward. And this is something we're hoping we can bring to Canadian women as a clinical trial. I'm hoping I'm not being too optimistic, but hopefully this year we will be able to move things forward in this regard. So this is a quick overview of where we stand and what we're hoping to achieve here in Canada with low-grade serous cancers.
Dr. Tinker, thank you so much for being here today, and especially thank you for your research focus on low-grade serous cancer. Not only are you collaborating on groundbreaking research, you also work, as you've said, in the gynae oncology clinic, caring for patients with ovarian cancer. I was diagnosed with ovarian cancer in 2006. And to say that treatment for ovarian cancer has changed in the last 15 years is an understatement.
Mm-hmm.
And as you've also just said, we now know that broad spectrum cytotoxic agents are typically not helpful in treating low-grade serous disease, and that we need molecularly targeted therapies. Can you tell us, please, how long you've been treating patients and how your treatment of low-grade serous disease has changed and improved over the years?
Yeah, thanks, Donna. Well, if I tell you how long I've been treating patients, you might figure out how old I am. No, I'm kidding. I've been working here at BC Cancer as an oncologist since 2006. Prior to starting here, though, I did do a research and clinical fellowship for a couple of years in the area of gynecologic cancers. So I've been at this for a little while now, approaching 20 years. I think I feel very lucky to have joined this field when I did, because everything started to change right around the time when I became an oncologist. We used to call all of these cancers ovarian cancer, and they, to us previously, were all just one disease, which is crazy to think of now, of course, because we've moved that paradigm's changed so much. But we now really care about these groupings, not only the histological, low grade, high grade, all that, but we really care about understanding the molecular profiles. We used to give a lot of chemotherapy to women with low-grade serous cancers, and really that's changed. We're trying to do all we can to avoid that. Hormone therapy as much as possible, and we really, really want the hormone therapy to work because it's the easiest to tolerate. Women feel well on it often, usually better than chemo, and it's often much safer. And certainly that's our first go-to. The MEK inhibitors are definitely now here. In Canada, they're not funded, but we do have access to them through the company that makes those drugs. So that's been a really nice opportunity for us with our patients. We do molecular profiling, testing of the tumor to see which genetic aberrations are there, as a very common thing that was not available. I mean, really, it wasn't even routinely available like 7 or 8 years ago. It's a very new change. So we're always looking at the tumor characteristics, trying to determine if there's something there we can find that will give us a unique opportunity that doesn't exist, before or otherwise. And of course, trials, right? We're trying our best to bring in these new options for women and record the results and hopefully share those results with others. Yeah.
Amazing and so encouraging for us low graders. And also one thing I wanted to ask you about, and I know that everyone who's interested in low-grade serous disease today will agree with me on this, and that is it's very confusing for patients knowing that the standard of care for low-grade serous disease varies widely, not only within Canada, but around the world. It seems like everybody's doing something different. I guess I can ask you, I don't know, would you like to say what's your standard of care, or can you speak to that?
Well, I think that reflects a couple of things. Number one, when you have a rare cancer that's not as extensively studied as the more common cancers, people start to interpret things their own way or approach the disease based on smaller studies or little series, or even their own experience, obviously. I think because we don't have that abundance of data that we might have for the other cancers we treat, it does give us more wiggle room. And that means there might be several very reasonable options and several ways that are, right, or at least not wrong, right? And there's going to be a lot of personal bias that comes into that. So for example, we work with our American colleagues a fair bit. They very strongly still believe that chemo should be an integral part of the first line treatment of low-grade serous cancers. Now that might not be uniform, but of the vocal people, you hear that. And you might still hear that a bit in Canada too. Others from other regions of the world might feel less strongly about that, and emphasize the anti-estrogen treatments more. It's, for me, I think it's a discussion with the patient, right? It always comes back to the person sitting in front of you and their profile and what their personal preferences are and desires and what are their immediate needs. Are they in severe pain and needing urgent treatment? Are they actually quite well? They don't have a lot of cancer. There's some time to make decisions. And you talk about these things. You have to discuss with every patient, what does chemo look like? What are the chances of benefit? What do these other treatments look like? What are the chances of benefit? What are the risks of all of them? Can we start with one and sequence through all of them eventually if we need to? Yes, no, why not? It's tough when you don't have really solid data to tell you, but I think you have to be open to that discussion with your patient. And the other thing, and Donna and any low graders out there, you guys are often in touch with other people. So sometimes the patient comes and says, hey, I heard of this. And you as an oncologist have to be open to hearing that and saying, yeah, okay, let's look into it. Is that good? Is it crazy? Can we do it? Should we? What's the risk? What's the benefit? Every patient is different, and the decision process has to be followed.
Thank you. It sounds from everything you've just said that it's, I shouldn't say confusing, but it's as challenging for you as a physician to know what the best path forward is when not a lot is understood. And thank you for considering everyone's individual priority. And Erin has a question.
Sure.
Thanks, Donna. Hi, Dr. Tinker. Thanks for giving us your time today. I really appreciate it.
Of course.
Well, I'm not a low-grade serous lady. I am of a rare subtype as well. I had a mucinous carcinoma. So I appreciate the fact that people like you, researchers like you, are investing your time in these more rare diseases. So could you take us through perhaps what types of challenges you face in researching a rare disease like ours, and why there seem to be so few clinical trials available for low-grade serous cancers?
Yeah, I mean, some of the challenges, I guess, are self-evident. So, when you do research, the best or most reliable research is usually done in large numbers of patients. Often the research might be like, for example, a clinical trial that we might expect to change care. That clinical trial would have to introduce a new therapy, but compare it to something old. And the way our systems work is we would expect the new therapy has to be proven to be better than something that we already have, because otherwise it's not viewed to be of any advantage to use it. So when large studies are done with large numbers of people, we can randomize some to the new treatment, some to the former treatment, compare them statistically, and we get, a lot of clever people to tell us how many patients we need to be certain that that difference we may be looking for is observed and is meaningful, and that we can be sure that it's a real difference, not just a random observation. That requires often hundreds of patients. And that with the rare cancers, that's only 5% of all the ovarian cancers we see in Canada. It becomes much harder to do those kind of trials. Not all patients are eligible for trials. Not all patients live in regions where they can come to a center for trials. So all sorts of things start to diminish, there's an attrition, how many people would actually be able to participate. And so there's just that barrier of having a rare disease and not being able to get high numbers of people to participate. That's one. The sad truth is, and I think probably the people on this call all know this, the people who have new drugs and money are usually our industry partners. Now, industry partners, companies that have these drugs, they do lots and lots of research. They really do try to bring a lot of good opportunities to our patients. The MEK inhibitor study that changed care was one of those examples. But when there's a really rare cancer, some partners may not choose to invest because they are also a business and they do not maybe always see how that will be a return for them in terms of their investment. Some of them will do it because they're, it's one of their company mottos to support rare cancer research, but some are less invested or willing. Sometimes drugs are going off patent. That's a major problem. If a drug is leaving it, the patent is about to expire, the company very seldom engages in a lot of research because they're now moving on to their next agent. They've done their development with a drug and no longer wish to invest. So it can be very challenging from those fronts. Even granting agencies, like we have several granting agencies in Canada, will sometimes acknowledge like this is a very important study that you are interested in doing, but is it feasible? Because it's a rare disease. Will you answer the question? I'm very grateful that Ovarian Cancer Canada has picked up our study as one to conduct, still acknowledging that we may or may not be able to complete this study. It will really depend on how lucky we are with getting it launched and successfully completed.
Thank you so much, Donna. I'll pass it back to you.
Sorry, Erin. Thank you. And thank goodness for Ovarian Cancer Canada making research a priority for the rare types of our disease so that every woman has a chance. Dr. Tinker, your research with Dr. Mark Carey has shown that there are distinct types of low-grade serous disease. Who knew?
Yeah.
In other words, your data has revealed unique molecular subtypes. We now know that every low-grade serous patient has potentially a different cancer from the lady beside them.
Yeah.
Individual subtypes behave and respond differently, which explains a lot about why outcomes can vary so widely in patients with the same disease. Your research goal alongside of Dr. Carey is to establish biomarkers, being a test to predict who will or who will not benefit from a drug, drugs like MEK inhibitors or anti-estrogen therapies.
Yeah.
So this would represent an amazing scientific advance. So can you please explain more to us about how biomarkers could help to guide the best treatment choices for patients?
Yeah, thank you, Donna. Biomarkers are a really hot topic in oncology research right now. So, alongside that trial that I've shown you, the one that we hope to launch with the support of Ovarian Cancer Canada, we intend to collect a lot of tissue samples from patients, archived, like those that are already stored in pathology labs, and also new biopsies. And we want to apply this new molecular classification that Dr. Carey's lab has identified to every participant in the trial to see which of those groups they fit into. And then what we want to do, if we're successful with what we've set out to do, is we want to correlate whether responses to our treatment are correlated to any specific one of these profiles, right? And the importance of that would be, although our study is quite small, it would be one of the first steps in trying to identify what tumor features actually predict the kind of response a patient might have to therapy. And that's a biomarker. A feature, usually a tumor feature that's biomarkers can be anything, but in this case, it would be a genetic feature of the tumor that predicts whether a response will be seen or not. If we can see some correlation between those baseline features and treatment outcomes, that will really let us develop future studies that are much more intelligent so that we can enrich our patient population for those patients that we think are most likely to respond to a specific treatment. So, if we can tell that patients with a certain genetic change never respond to a MEK inhibitor, that would be helpful, because why would you put a patient on a toxic drug that 30% of women can't tolerate? We would avoid the toxicity, and maybe we would be able to tell that their tumor is very, very specifically sensitive to pathways that target the estrogen pathway, or drugs that target the estrogen pathway. So we might choose to study new drugs that target the estrogen pathway instead and put them on that. I see a quick note that came up that's very promising. That is truly our hope, is to stop subjecting women to random treatments because we can't pick who responds and who doesn't. And really try to be a lot more intelligent and say, look, we see this in your tumor. 90% of women with this change do well on this treatment. We want you to have this treatment. That's the future we're heading towards. So this is the work that will start that process. What's really great for the group I'm working with, and the credit goes to Dr. Carey because he's just been tireless at this. He's working with a lot of international collaborators, all of whom are really interested in this disease. So the findings that we make here, I think, will translate very quickly into a larger research setting amongst other countries and other collaborators. And we might be able to accelerate, these discoveries into research and trials around the world. So it's exciting. I really want to see this type of opportunity, this type of trial go ahead. Yeah.
Amazing. Thank you.
That's so inspiring to hear, Dr. Tinker, that the work done,
Wow.
partially funded by Ovarian Cancer Canada, will be translated so quickly to other women and other patients around the world. That's really wonderful to think of our teal sisters globally. Following along the lines of what we were just discussing with Donna, can you explain a little bit about how you and your colleagues are rethinking phase 1 trials? So taking on this note of, instead of making patients sick, making the cancer sick, and reducing toxicity by reducing doses and combining drugs?
Yes. Well, yeah, there's a lot of interest in this. A lot of these drugs that are not the conventional chemotherapy drugs, there is a difference between what we call, in chemo, we used to find the maximum tolerated dose. We would try to get to the highest dose that is safe to give to a patient. But with some of these drugs, there's a disconnect between what is the maximum tolerated dose and what is the effective dose. So that's one thing that's very important. And then the other thing is, sometimes there are interesting synergies. So you might combine drugs that work in slightly different pathways, but those pathways are both important for how a cancer will respond to treatment. And by making the combination happen, you need much less of both drugs. Whereas if you only used one drug, you would still have to go with the higher dose. So these are really wonderful sort of strategies to try to give less toxic treatment, but effective treatment. And of course, the perfect scenario would be is if we had a biomarker to tell you you know, this is the treatment you should have. You can have it at low dose because we know these drugs work well together. That would be ideal. Yeah.
Thank you. I think we are way over time on our session, unfortunately,
sorry.
and I have so many questions that I still wanted to ask you. But as a low-grade Serous patient myself, and on behalf of my community, I just want to say thank you, Anna, for focusing on our disease as a separate entity. And is there anything else that we haven't asked you that you would like to say?
Off the top of my head, only just really want to thank, well, all of the participants, women, advocates, Ovarian Cancer Canada, who have just worked so tirelessly to make, you know, these wonderful opportunities happen, and for sharing our message, and, you know, just reaching out and making sure that all the women who have this disease and other ovarian cancers are well informed and connected and speaking to each other. So thank you all. Yeah.
Thank you.
Thank you so much.
Dr. Tinker, I wanted to thank you too for your overview and explaining low-grade serous carcinoma in words that I could understand. And also for your expertise and honesty in answering some really tough questions. So I appreciate that. And Donna and Erin, thank you both as well for taking the time this evening to share your knowledge and experiences with us. As part of the audience, I know it's really incredible to be able to learn from lived experiences like your own. So thank you both. So now that wraps up the first half of our evening. So we're running a few minutes late, so we're going to have a 10-minute break. I would encourage you to get up and have a stretch, and we'll meet you back here in 10 minutes.